Okay, I'm going to go ahead and open up that waiting room so we can start getting people in here. Here we go. Good evening, everybody. I'm Nan. I work with ACHE. I'm going to be your tech support tonight for our Zoom event. I'm just opened the waiting room up. I'm going to wait just a little bit. We have a good sized group tonight, so I want to make sure we all get connected and can hear. And if you have any questions or are having any difficulties, feel free to reach out to me in the chat. I will reach right back out and see what I can do to assist. Or if you want, yep, I was just going to say, let us know where you're from. So, Regina, North Carolina. So, I'm in Illinois. I'm in Chicago. We're still in the 60s in Chicago, if you can believe it. It's supposed to get colder tonight, but. All right. New York. All right, everybody. So I apologize. I'm looking in two different areas here, trying to keep that waiting room from filling up as we have people join us. But like I said, we have a really good sized group tonight. So I want to get us started so we can get in as much time as we can. Welcome. On behalf of the Healthcare Leaders of New York, I welcome you to our event tonight. And just before we start, I'm going to go over just a few little housekeeping things. The event is being recorded, so if you miss anything and would like to watch it in about 2 business days, it'll appear on the learning management system where your courses are located for ACHE. So just go ahead and go there. We also will be having a evaluation link that you will see in the chat every so often. I also will put it in right at the end so you can grab it. We really appreciate any input you can give us and ask that you complete that evaluation after you finish the event before you finish your evening. We will also have the session is worth 1.5 hours of our ACHE virtual interactive education credit. You do need to be logged in for the entire session. And if you meet the requirement, that will post in about 10 days. And that is also to in the learning management system where your courses are located. Again, the chat, please use that for questions. If you have a question as you are going through the event, you can put it in the chat at that time. We also will have time at the end, but don't hesitate to put that in there. We will try to address them as we can, or at the end if we have enough time. I am going to be spotlighting some of our panelists and speakers tonight. You do not have to keep that view if you do not want to. You are more than welcome to go into the right-hand corner of your screen where you see the word view and change it back to gallery. It can help sometimes when you can see the panelists and the moderator. And since we do have such a big group, it'll help make things a little clearer. So I just wanted to point that out, but you don't have to keep that. All right, I'm going to stop talking. So I'm going to let our session start. I'm going to actually turn this over to Carl Marie Mennon, who's going to get us started. And again, in the chat, you need anything, just let me know. Thanks, everybody.
Good evening, everyone, and welcome. My name is Carl Marie Memnon, and I'm the 2024 President of Healthcare Leaders of New York, HLNY. On behalf of the board, welcome to our Integrating Acute to Post-Acute Care Settings. Where do we go from here program? Healthcare Leaders of New York is the local chapter of the American College of Healthcare Executives, representing over 1,900 professional members in the New York metropolitan area, providing access to networking, education, mentoring, and career development, all at the local level for our members. Our mission is to advance healthcare leadership and management excellence through professional enrichment and continuing education of our members. This evening, we will hear from healthcare executives who have expertise in post-acute services. Our population changed, so must the delivery of healthcare services along the care continuum. Acute care hospitals are facing with ever more regulatory requirements and expanding financial penalties, all to alleviate the standard of care across the healthcare system on a national level. Driving forces are pushing acute care hospitals to work collaboratively with members of the post-acute care continuum to cohesively manage patient populations through increasingly more aspects of a patient's post-acute care progression. Next slide, please. Our moderator for this program is Natasha Ellie Lewison, the Vice President of Operations and Ambulatory Services at Calvary Hospital. With expertise in post-acute care and growth strategies, she holds a degree in health informatics, nursing, a Master of Health Administration, and is a doctoral candidate with a focus of institutional theory and its impact on advanced care planning, along with credentials as a licensed nursing home administrator and fellow of the American College of Healthcare Executives. She has been successful in implementing clinical care programs and transitions of care that reduce the length of stay, as well as manage the readmission rates at acute care facilities. She has had great success in revenue enhancement, leading capital projects, submission of certificate of need applications, and managed the construction of ambulatory wound care clinics, outpatient rehabilitation, transitional care units, and senior housing apartments. Now, without further ado, I'm going to turn it over to Natasha. Natasha?
Thank you, Cara Marie, for the introductions. And welcome to our audience who are logged in right now. And welcome to our panelists who have decades of experience in the post-acute care realm. So let's get to know them. We will start with Scott Elderman, followed by Scott LaRue and Nancy O'Toole. Scott?
Natasha, thank you. And you said decades of experience. I have 3 decades of healthcare experience, 30 years for those who are keeping score. Seen a lot of change in the healthcare landscape. More recently, more change. The post-acute environment is a landscape that changes every day because of regulatory, insurance, financial threats. Before becoming the executive director, CEO of Burke, I was the CEO. So I like to say I know where the bodies are buried, and I might have put a few there. And really excited to be on this panel. Thank you.
Yes, good evening, Scott LaRue. I'm the president and CEO of ArchCare. ArchCare is the healthcare ministry of the Archdiocese of New York. I've been at ArchCare for a little over 17 years, and about 15 of those as CEO. And I look forward to speaking with you and the fellow panelists here this evening on this topic. I don't think it's ever been more relevant than it is today. Without this collaboration between different levels of care, none of us are going to be successful. So I look forward to hearing what my fellow panelists have to say this evening.
Thank you, Scott. Nancy?
Good evening, Natasha and others. Thanks so much for the opportunity to be here. I too have, I guess it's 3 decades of experience in healthcare, really ranging from the inpatient to outpatient, and most recently for me, the post-acute care setting. I also spent some time on the healthcare consulting side with Ernst & Young in their healthcare consulting practice based in Chicago. Today, I'm vice president at NYP for post-acute care services, and I'm also leading NYP's effort into the hospital at home space. So I do look forward to our conversation. Thank you.
Thank you, Nancy. So now I would like to start with the first question. So we want to know who's in the audience. So can we launch the first question?
But hang on one sec. Here we go. Should see it up on your screen. We got a little over half that have answered, so keep on going. All right, I'm going to give it 5 more seconds, and then we'll go ahead and close the poll. So we'll go with 5, 4, 3, 2, 1, and let's share the results. Hopefully you can see those.
Is the audience able to see them as well?
They should be, yes. Everybody see them okay? Let me know if you can't. It says they're sharing. Yep, they can see them.
Okay. So 13% of our audience are students. We have 3% as early careerists, 25% as mid-careerists, and 58% are representing executive or senior management, and 3% are others. Okay, very good. We have one more question that we would like to share.
All right, let me grab that poll. Hang on one sec. Here we go. And you should see it. If you work in a post-acute setting, which type do you work in?
Oh, I'm not seeing it.
People are Natasha, you're not seeing it?
No.
Oh, well, we got people answering, so hopefully
Okay.
I will go ahead and make sure we get you the results. We've had 22 out of 55, so a few more want to answer. Maybe a few more seconds. Might not be as many this time. All right, let's go with 5, 4, 3, 2, 1. And I'm going to end it and share the results. And hopefully, Natasha, you'll see those.
I see
Okay.
them now. Thank you.
Sure.
All right, excellent. So we'll start from the bottom. Okay, so we have 60% who are 62% who represent outside the post-acute realm, but we have 8% who are representing RRFs, 8% representing LTACs, 50% representing the SNFs, and 8% in home health agencies. So very good, excellent. So thank you for the pull up the questions, Nan. So let's get the conversation started. But before we do that, we want to start by defining what post-acute care is. Post-acute care is a critical phase in the healthcare continuum, focusing on the recovery and rehabilitation of patients after they have been discharged from an acute care hospital, but still require medical attention and support. The primary goal is to help patients in ensuring a smooth transition to regain their functional abilities, manage chronic conditions, and transition safely back to their homes, as well as long-term care settings. In essence, post-acute care bridges the gap between hospital care and home and nursing homes or long-term care facilities, providing a comprehensive support system that facilitates better health outcomes and improved quality of life for our patients. There are several types of post-acute care services that we will hear about today. These settings include RFs, which are the inpatient rehabilitation facilities, skilled nursing facilities, also referred to as SNFs, home health care, hospice services, which covers patients who are at the end of life, long-term acute care hospitals, also referred to as LTACs, and of course, our assisted living facilities and long-term care nursing homes. Each setting is tailored to the specific need of the patient, aiming to improve their quality of life as well as help them regain independence. The Agency for Healthcare Research and Quality reported approximately 7.9 million inpatient stays were discharged to post-acute care hospitals. Post-acute settings. Which accounted to 22% of all hospital discharges in 2013. Yes, the data is dated, but the statistics remains relevant. Post-acute care services is a crucial discussion topic to our population who needs these services and continues to grow. So let's start with our first question, and we'll start with Scott LaRue. What does care collaboration along the post-acute care continuum looks like?
Thank you,
Scott?
Natasha. Before I quickly answer that question, just to give a little background, ArchCare offers the entire post-acute continuum from nursing home, inpatient, rehab to home care to hospice to PACE programs to assisted living. So we kind of have a ship in every port here as it relates to the post-acute. So just to give the audience some perspective on my answers, but post-acute collaboration and successful transitions of care starts with a trusting partnership with one of our referral partners, be it a hospital I think it has to start out with each partner having equal respect and understanding for what the other party does, the challenges that each of them face, and a willingness to look at the relationship holistically and how you can not just be focused on, what referral you're getting and what the payer source is, but the circumstances that that partner and the people you serve are coming from, and how you can be a full partner in solving those problems. I think the collaboration is only successful through ongoing communication and timely sharing of data and information. Having clinical partners on either side that are speaking to each other regularly, sharing information about the patient, whether it's clinical, it's behavioral, whether it's the family, or whatever the circumstances might be, that makes it could put a challenge on the post-acute provider. A heads up and an understanding of that entire picture makes for a smoother transition and less bounce backs to the partner. So communication, I'm going to put at the top of the list, as well as equal respect and concern for both partners' issues as well as the patient.
Good point. Nancy, would
Yeah,
you like to comment as well?
Sure, I couldn't agree more with Scott. I will say, because I realize folks are not all from New York, just for context, taking a cue from Scott, I work for New York Presbyterian. New York Presbyterian is a large health system in New York. We have 9 acute care hospitals. We have a behavioral health hospital, and we have over 450 locations throughout 5 boroughs in New York. We also are partnered with 2 medical schools, Cornell and Columbia. So it's a large health system, just for context. And so back to Scott's comments, it all begins with communication and mutual respect. I think that is kind of the framework and the groundwork for a strong collaboration. And that should happen at multiple levels. So physicians should be speaking, the care team should be speaking, care coordination and social work and the admitting, leadership. And I think when you have those communications happening at multiple levels, it becomes successful. Likewise, I would say once you get to the point where you've developed those strong relationships and really understand each other's needs, you can then work together to build kind of customized programs. I would say that's really critical, that we develop programs together to meet the needs of our mutual patients.
Well said. Scott?
Thank you. So Nancy and Scott L., thank you for, let's put everything in context, right? I'm in New York, I'm in Westchester County. I'm in charge of a 150-bed inpatient rehab facility, and our primary focus is on neurological cases. That being said, we have 13 outpatient sites, and we do over 200 outpatient visits. So let me kind of come at it the same way and piggyback on what we all said. First, you have to have a willing partner, and you can't have a favorite child, okay? You can't favor your own health system because there's other organizations that need help with throughput. I just finished writing an op-ed piece about the throughput crisis and how the post-acute sector can assist, because there's a logjam at the acute hospitals. So care collaboration means to me willing partner, communication, single point of contact, because it gets a little cloudy, little blurred lines on who do I call on the weekend. You have to have 7-day coverage, open channels. Understand that both organizations have a common goal, and it's the patient. And Scott, I couldn't agree with you more. Sometimes organizations are hyper-focused on the payer source, and I apologize for healthcare every day. That's where it's broken. We need to make sure we have patient and family engagement, utilize technology, and a shared electronic medical record system really helps streamline the process.
Scott, do you want to talk a little bit more about throughput? Because I know that's a new terminology that we're using in order for us to get patients into the hospitals and
Yeah.
going to the transitions.
Sure. So acute care hospitals, and I saw there were a lot of students on the poll. Those are your regular general hospitals. That's Nancy's New York Presby Lawrence or Columbia Cornell. That's my sister organization, White Plains Hospital, the 3 Bronx hospitals. We're having log jams there. The acute hospitals are full. There's no place to put them. The bases are loaded, and those patients are not ready to go home. That's where we come in. Everybody on this screen comes in with a solution, and there's no one-size-fits-all approach. It has to do with the diagnosis, the comorbidity, and what a patient can handle at that point in time. And sometimes an IRF, an inpatient rehab facility, is the right setting. Sometimes a SNF is, sometimes an LTAC, sometimes home with home care. The goal of what we're doing here as a post-acute continuum is get the patient back to the life they love. But in the interim, let's make sure we're choosing the right setting. All of the acute care hospitals are saying, Scott, have you heard that radio station, WIIFM? What's in it for me? How can you help lower my length of stay? And that's where we all come in, and that's where the collaboration comes in on how can we move this patient regardless of payer source.
Anyone, Scott Loritz, did you want to add in, Raymond?
Yeah, it's I understand the throughput issues that Scott was referring to. I was just reading just before we got on this panel. I think it said there's over 7,000 nursing home beds that have closed nationally.
Yeah.
And New York State isn't any different. The reimbursement system is broke, and until it's fixed, there's going to be continued decline in the number of available beds, and trying to solve that throughput becomes even more difficult, and the focus moves to more home and community-based service type options. Very similar, whether it's home care, it's PACE, it's assisted living, it's the hospital at home program that many of our partners are running. People prefer to be in a community setting, but at the end of the day, there's a certain percentage that are going to need institutional care. And until we solve this problem around reimbursement, I think it's going to be a really challenging period, as Scott just mentioned.
And Scott, just to piggyback what you said, I was at a Westchester County Association meeting this morning, and there were some state government people. New York State pledged money for Medicaid, especially for nursing home side, and has yet to release the funds, and it's a 1.5 years old.
So let's move on to our next question, which we'll start with Nancy. What are some best practices with post-acute providers to enhance collaborative relationships with Nancy? Okay. What are some best practices with post-acute providers to enhance collaborative relationship with providers upstream in the acute care hospitals and with providers downstream along the post-acute continuum?
Sure. Well, again, it begins with that idea of communication. I would say a good strategy is establishing cadence meetings. So ensuring that you've got a regularly scheduled meeting on the calendar with the post-acute care provider to check in. How are things going? What's new on your side? What are your priorities? Here are some of the challenges we're facing. Can we think about potentially developing programs together? I think that's very important. We try to do a better job of it. There isn't enough hours in the day to meet with all the folks we'd like to speak with, but I think that that's a really important strategy. Another thing that we've recently done is we've developed what we call post-acute care specialists. So we have a core on our team that really work hard to get to know the post-acute care providers through site visits, through making connections and contacts, through understanding what the post-acute care providers need for some of our more complex patients. And so they end up becoming kind of the key resource for the post-acute care providers, but also a key resource on the internal side. So I think that has been a very productive program that we've implemented over the last year.
Excellent. Scott Elterman?
Nancy, just to, take another step to what you said, 7-day-a-week feedback loop. Go back to my single point of comment. Communication has to be at the highest level, and you should not take any relationship for granted. And I agree with you, Nancy. The folks at the acute hospitals should make regular visits to the post-acute setting and involve social workers, case managers, family visits, and also provide a KPI dashboard back. How many referrals were received, how many we reviewed, how many were denied, and why, because you need to know what good looks like, and maybe an understanding on how to write a note where when the big bad insurance company gets a hold of it, they can't say no. And referral relationships are gentle. Don't make a mistake. And be careful on a patient you say you're going to take, and that patient gets 911'd out because you couldn't handle that patient. And also service lines. I love what you said, Nancy. Let's develop service lines together. In 2024, we established inpatient dialysis. So if a patient needs rehab, we can now give them hemodialysis 3 days a week. A year ago, 20 years ago, 2-3 administrations before me said it couldn't get done. We never used the word can't. Got it done. 4 months in, we've taken care of 40 patients that might have gone to the wrong setting that needed the intensity of 3 hours a day. And some of our referring hospitals were beating them over the head with it, still say, oh, we didn't know you take dialysis patients. So it's that constant feedback loop and integrated care model.
I learned something as well. Scott LaRue?
Yeah, I think some of the best practices that we found that have been very successful is going back to the shared information. So you can start with education. So if we're working with a particular partner and they have clinical pathways that they like to use, we of course had clinical pathways, but we don't generally get into a debate about whose clinical pathway is better. We usually defer to our referring partners. We make sure that the education that they're using to train their staff is consistent with what we're doing and how we're training our staff. And that way, when the patient arrives at one of our programs, the approach to their situation is consistent, as well as the expectation. When they leave the acute provider and their discharge plan, it should be telling them what the expectation is in the next setting and what the goals are of that and when they think they should be able to achieve either discharge or movement to a lower level. We found that sharing clinicians, depending on the partner, we have actual staff clinicians from some of our partners working in our homes. Some of them are employed by them and some of them, we employ. But it just ties that clinical team together tightly. If something's going on with one of those patients, they know who at the hospital to pick up the phone and speak to. There's physician to physician discussions, as Nancy talked about. If on transfer, someone's coming over on a medication that they expect to be in our facilities for less than 13 days and it costs $6,000 a week, having a conversation with the doctor at the referring partner about options and alternatives that achieve the same clinical outcome, but get the cost in a place where we can accept that patient and care for them. So I I just go back to the more you share information, access to the electronic medical records. If you aren't fortunate enough to be able to have Epic, there are ways that Epic provides access to some of the partners, and you
Right.
could get in and see what was happening in the hospital for that particular patient. And on the flip side of that, if they go back to the ER, you could track them in the ER, you know what's going on, there's a dialogue, and you get them back to the lower intensity care setting as quickly as possible. Those are some of the best practices that we found, that help have a successful outcome for the patient.
Excellent. And we understand that over the years, please, I'm saying this to the three panelists, we know over the years, things have changed of what nursing facilities are able to do and what Burke Rehabilitation is able to do. Do you want to speak upon that? Because I know once upon a time, it was looked upon that it was very limited as to what the facilities could do. But now we're starting to see that there's more, the acuity is increasing, right, of our patients, and the collaboration to transition our patients as timely but as quickly as possible to the right setting is crucial to the acute care hospital. So anyone want to give some feedback as to how things have changed and how the collaboration has helped our patients?
Yeah, I think wraparound services are key. Starting off with the complexity of the patient. Acute care hospitals want our settings to take the patient quick, and sometimes it might be too quick, but we need to make sure we can handle that patient and understand the wishes of the referring hospital should something go sideways. I want my patient back, New York Presby tells me, unless it's 911, what's your emergency? So again, goes back to communication, understanding the specialized services, understanding a patient that's on a pump, not on a pump. Can you handle it? What's your wound care protocol? You want to reduce pressure injuries, reduce falls. What do you have that makes you different?
Yeah, I would add, Natasha, what we're seeing is a really strong willingness to be creative with our partners and to develop creative programs. And in some cases, that means the acute care setting, providing education and training to the post-acute care team, but really developing these programs together. One example is we've been recently working with some of our post-acute care partners on their ability to accept patients on NG tubes rather than with PEGs. And it is something that our physicians have been very passionate about. And so we together have been developing a pathway for that. That's one example. We've certainly done some innovative things with Arch Care around what we call a multi-layered discharge program. So thinking beyond, for example, the skilled nursing facility, what is a discharge plan for that patient? And how can we partner to make sure that we're thinking about that entire pathway? So that's just a couple examples, but we're really pleased with the openness and the willingness to be creative and innovative that we see with our partners.
Yeah,
Excellent.
I would definitely say, we used to say 10 years ago that the folks who used to be in higher levels of care were now in the nursing homes, but it's grown exponentially, the acuity of the patients that we're taking into our skilled nursing facilities and our rehab units. A perfect example for us is we're partnering with an oncology program here in the city, taking patients who are being actively treated for some type of cancer diagnosis. That was something that we couldn't do before the reimbursement system changed on the Medicare side, called PDPM. But PDPM is given a broader opportunity to take patients that you couldn't have afforded to take under the RUG's old therapy system. So, IVs, PICC lines, oncology patients, cardiac rehab patients,
Right.
I really think the rehab side of the skilled nursing facility is more acute than what you would have found on a gen surge level in the hospital 10 years ago.
Absolutely. Should we go to our next question? Okay, we're gonna start with Scott. What strategies can we implement to reduce the readmission rates to hospitals by post-acute care providers? Scott Elderman? Are you there? Okay. Okay, Scott LaRue, would you like to take the next question?
Sure, I'd be glad to.
Okay.
You know, we're very, very focused on readmission rates and how we prevent unnecessary transfers back to our referral partners. And some of what I already shared about the communication, sharing the electronic medical record, having direct contact with the physicians and the care team at the referring partners hospital. But at the same time, it goes back to the skill level, the education, and having the proper supports at the nursing home so that you can take care of these more acute patients. And when something, you know, goes a little awry, you're prepared to deal with it and you know how to deal with it, and your staff has the confidence to deal with it. In addition, we set up protocols within the nursing homes so that readmissions, you can't just call a physician at 2 a.m. and the easy response is for them to say send them to the hospital. If it's not a 911 type situation, they've got to get the medical director on the phone. They have to have a conversation with the medical director, and he or she can give direction to the staff. It makes them feel confident in the decisions that are being made and supported, so that they're comfortable caring for that patient. It's been a cultural change. It used to be the easy thing to do when things got difficult was just send them back to the hospital. But if you did that in today's world, first of all, you're not being fair to the patient, and secondly, you're not being a good partner to the hospitals. And you started out with these bundled payments under these value-based arrangements. Not many hospitals here in the city took part in the first phase of that, but it taught a lot about how to work together and what you could do to keep the patient in the right setting for them and avoid them returning to the higher cost setting. And now CMS, as you know, is coming out with the team bundles, and hospitals have already been selected, and it's mandatory. And there's going to be a 30-day risk here. We're in a situation that we're fully prepared to talk to partners about taking full risk on discharge from the hospital. We're confident that we could manage them either within our subacute units, our PACE program, or through our CHOP. So you got to have talented clinicians. They've got to have confidence. They've got to have the support around them. And I think that's how you keep your hospital admissions down.
Nancy?
I'm happy to add to that. I think on the hospital side, we also have to make it very easy for our post-acute care partners to access us and connect with us real time when there's a readmission being considered, because potentially we could troubleshoot. Sometimes I think it's difficult, certainly in our system with as big as we are, for the care teams to find the right people to speak to. So I think we've got to make that part very easy, and then ensure when we do have a patient coming back that our ED team to understand what it's for. And perhaps it's not, in fact, a readmission that's needed, but something else that's needed and the patient can be returned. So I think we certainly have opportunity, and it'll be something we'll be focusing on in 2025.
Yeah, and full disclosure, Nancy and ArchCare and New York Presbyterian have worked together for a number of years. And I think Nancy touched on this earlier. We kind of have a three-pronged level. There's the daily clinicians that have conversations and talk to each other. Then there's a mid-level that maybe doesn't speak every day, but certainly speaks regularly. And then we have an executive level partnership meetings that we do a couple of times a year. So everyone knows, if necessary, how to elevate the issue or the question to get a resolution. And it's always done in a collaborative manner. So
yeah, and that's a great point, Scott, that maybe I almost take for granted, that we can pick up the phone and people do that, and people are responsive both ways. So Scott can certainly call me. I know I can call Scott. I can call members of his team. And I think being very responsive, again, back to Scott's earlier point about respect, is important and really just fosters a strong relationship.
What it sounds like is really, it all comes down to the communication, because working for a SNP and dealing with different types of populations that are coming in the you have the family dynamics as well. Communication really drives the process of reducing the readmissions to the hospitals. So I know Scott mentioned something about risk associated with taking patients. Do you want to elaborate on that, what the risk is with us on the post-acute side for bundles?
did you want me to take that?
Yes, Scott.
Yeah, we were talking, I was mentioning the new mandatory bundled payment program that's coming out called Teams. And under this program, certain procedures or diagnosis are automatically going to be paid as a bundle for the hospitals that have been selected to participate. And there's a 30-day look back and a full risk for the hospital in terms of what happens to that patient on that 30-day period. So they're going to be looking for partners who do exactly what we've been talking about tonight, and can demonstrate that they're able to manage the patients and avoid unnecessary bounce backs, and can get them to a lower level of care as soon as they're appropriate for that setting. A lot of us go get the CMS data that comes out every December. Of course, there's an unfortunate lag in the information. You can compare yourself to your partners and see what your length of stays are, what your hospital readmission rates are, and compare yourself to everyone else who's being discharged from that referral partner, and see how you fit in that. And it can point you in the direction of what you need to do better so that you could be successful. We're fortunate in ArchCare that we've had a large managed care portfolio. It's taught us a lot about managing risk and taking risk. So it's part of our culture. It's something that we're used to doing. I can certainly understand the hesitation for a smaller facility or program that hasn't had a history of taking that kind of risk. But that's what's coming with Teams. So you're either going to be prepared or not participate. Nancy, what's your hospital perspective on it?
I agree, Scott. We are ramping up to develop that strategy. So lots of conversation happening, but to your point, it's going to be really critically important that we've got those pieces in place and those connections in place to manage that patient's stay together and their care together. So again, it just ramping up the collaboration and the communication at all levels. So yeah, it'll be a new place for us, but I think we'll be ready for it when the time comes with, the conversations and the work that we're having today. Looks like Scott Edelman's back.
I'm back, so I had some computer issues. Nancy, to your point, choosing the right partner is key in bundling. Communication, collaboration, and making sure there's no log jams, because now we're all, quote unquote, at risk. And we need to manage length of stay at all settings. We need to manage the expectation of the patient, the family, the caregiver. We also need to make sure that we understand that community resources are not plentiful. So we might have to develop our own as part of this whole bundling. We're fortunate in our hospital, we have what's called a caregiver center. You know, patients are in my hospital because a traumatic event occurred and they don't know what happens next. So we have a caregiver center that's run by a full-time social worker with the resources to say, you know, Mr. and Mrs. Smith, you know, your loved one had a traumatic event. They might be able to go home, but they might also need these services, connecting them with those wraparound services, coordinating the next level of care, which is a follow-up with their physician or a follow-up with the neurologist. They might need neuropsych, they might need regular psych. It's recognizing all the signs and then each other's shoulder.
We didn't hear the last part. Scott, do you want to repeat that last line?
I said we have to tap each other's shoulder for help.
Yes.
It's the Game
Absolutely.
of Thrones of healthcare, but during COVID, we were good friends. So during bundling or referring, there's no secret sauce. We should be working together better.
You're 100% correct. I mean, during COVID, it was a very difficult time, and we seem to all come in line and put our forces and our minds together. So, excellent point. Before we move on to the next question, does any of the panelists want to continue on other strategies to reduce readmission rates to the acute care hospital?
Yeah, I make a couple of comments because my original comments were focused on, you know, transfers within institutions, but there's also the discharge home. And then, you know, you can't discharge them from your facility and send them home and not speak to them again. You've got to follow them home. You've got to call them up. You've got to make sure they know what they're supposed to be doing as it relates to their medications and their care and their doctor's appointments. And if you don't monitor that, they're going to be bounced back to the hospital during that 30-day period or after. So this bundle that we've been discussing is actually better because it's a shorter period of time than the first one was. But you know, your responsibility doesn't end when they leave your facility. You got to stay on top of it. You got to make sure they have those wraparound services that Scott spoke about, and you've got to make sure that your home care services show up when they were supposed to. The DME gets there, the medications are there, and they know how to get to the doctor when their follow-up appointment is due.
Also, I want to add one other thing about social determinants of health. And we need to recognize that some patients do not have those resources. So whatever we can do as an organization, we're fortunate. We have a fund called the Safe at Home Fund. And we have a 10 questions on admit to ask certain questions about food insecurity, medication management, etc., which helps us diagnose a barrier to discharge. It may mean that they need a week's worth of medication because they can't afford the copay. You know, that's what this fund is for. And the grateful donor told me every year, call me on New Year's Eve, and whatever I need to put back in, I'll put back in because it's that important. But organizations, not all organizations have that luxury, but we have to recognize that we need to make sure, and I love what Scott said, when the patient leaves you, you can't just say goodbye. The needs follow-up. Follow-up care is important. Community check-in. And what we've been trying to do is have the team that took care of the patient do the follow-up call. And they're more likely to take that call and say, oh, Brenda, you're the nurse who took care of me. Yes, I'm doing well. I'm taking my medication every day. Very important connecting point.
The transitional care management of the patients are definitely key to both Scott's point, especially when they're returning home. You don't want them to go home and then bounce back. Nancy, do you have any input?
Yeah, completely agree. We also, to the extent we can, we have outpatient care managers who do just the things that Scott and Scott were saying, checking in. Have your home care services arrived? Has your DME arrived? Do you have questions about your medication? Have you made your follow-up appointments? All in the spirit of trying to make sure that patient is home and stays home safely. And we'll check in with the patient periodically as well over a period of 30 days. So that is a program that we offer. It's not widespread. We're looking to expand it, but I do think that that is critical for keeping patients in their homes and not coming back unnecessarily because of a medication misunderstanding or because there was a miscommunication with perhaps the home health services and the timing didn't work out. So really critical to make those connections with our patients.
So let's move on to the next question. How do you achieve buy-in from partners along the continuum of care? I know we spoke a little bit about this, but maybe we could discuss the role of technology, data sharing, and improving continuity of care for our patients. But how do you achieve buy-in from partners along the continuum of care? We'll start with Nancy.
Well, I actually was going to go, Natasha, in a slightly different direction with this. I think a big piece, we've made it clear that communication and relationship building is key to buy-in. I also think site visits, so that the two teams can see each other. I mentioned my post-acute care specialists. They're making a point of getting out to seeing our post-acute care partners. It just allows them then to speak about the resources and the commitment and the expertise available on the post-acute care side with our internal teams. So I think that helps create buy-in and collaboration on both sides. I'll let the Scotts comment on some other aspects of your question.
Go ahead, Scott.
So I also think all the relationships are great. Feedback loop is great, but we can't ignore speed to market. We have to be able to make a decision quickly. If it's no, it's no, it's the wrong setting. But we also have to understand that there are usually two pathways to admit. One is the clinical pathway, and the other is the big bad insurance companies. And with the big shift now for the post-acute population, from traditional Medicare fee-for-service to the Medicare Advantage plans, which I've renamed the Medicare Disadvantage plans, could take some time. Could take 1 to 3 days for the MA plans to say no. As Medicare fee-for-service, I saw a chart today that one of my folks gave me, and it was the last 6 months, the percentage of the entire federal population that moved from traditional fee-for-service to the Medicare Advantage plans, the Aetna Uniteds, the Blues, and whoever else is, selling them. So we need to be aware that sometimes that's a barrier, and that's where leaders of organizations need to talk to the payers and say, how can we be pioneers where payer and provider meet and we do the best for your subscriber? So we can all talk about our relationships, but we also have to have those payer relationships, because we can clear a clinical patient 3 hours or less, but that insurance logjam with prior authorization has been a thorn in all of our hospitals in New York and outside of New York as well.
Good point.
So achieving buy-in from our partners along the continuum, I think that takes time. You've got to build trust. So the things that we talked about here today, I don't think you can roll out tomorrow and work on the 8th floor when you don't have the 7 floors before you as the foundation in place. And it takes time to do that. And you got to prove to your partners along the continuum that you truly want a win-win relationship. It goes back to solving problems for your partner. And after you solve enough of their problems and they know that you do want win-win and you do care, they're going to start solving your problems. And then it becomes this mutual relationship where you're both working together because you trust each other and you trust the work that each is doing and what your objectives are. And when things are difficult, that you're going to work together to solve those problems. No one's coming in with a hammer over the other one. It's a joint discussion about why did this happen? How could we prevent it from happening again? And when you have that kind of relationship with your referring partners and your CBOs and other community partners, you're going to get buy-in from them. And that is really when you know that you're humming along at the level of a relationship that's going to be successful.
Good point. So Scott Edelman actually mentioned something about partners with the managed care companies. So how do we manage that, actually work with them? Because they're actually one of our partners. So how do we manage the insurance companies to actually get the services that our patients need in the post-acute world?
So I'm going to jump in and say, when your contracts are up and you're renegotiating a 1 to 3 year deal, whatever it is, you can have all the no denial clauses in the world in there, but there's always going to be a way that the big bad insurance companies, you want priority and you want to be able to identify 5 or 6 diagnoses and request, may I admit these patients without getting prior auth because they're spinal cord injury or they had a stroke, and we can case manage it later and learn from the data. And if I took one I shouldn't have took, well, let's find out why. But of these 10, 9 of them were the right type of patient. And what we did is we helped the acute and we got the patient to the right setting quicker. But, just like Scott L. said, that doesn't happen overnight.
Yeah, Natasha, if I knew the answer to this question, it would solve a lot of problems for me.
I know.
It's really difficult, when you're dealing with for-profit insurance companies whose goal is to improve their shareholder value. At the end of the day, they report to their shareholders. We're fortunate here in our market. We've got a number of nonprofit insurers that you could do some real shared programming with and do things that benefit the patient. But it's a real challenge. In our home care agency, we've actually had to put the insurance companies in various tiers or buckets based on how they pay us, which I hate to do as a nonprofit and a mission-driven organization. But you've got some of the largest insurance companies in the marketplace trying to pay you less than it costs simply for the nurse to go to somebody's house, no less overhead or any other expenses related to running a home care agency. They want to pay you less than it costs to pay the nurse's actual salary. So this is a tremendous challenge, and how this gets resolved. I'm not sure I won't be retired by the time this is fixed, if it ever is.
No.
Right.
And one other thing, you made a point, Natasha, during COVID, we talked, we were good. We were also asked by New York State to flex and surge and take patients. And there was some prior authorizations. Guess what, folks? Were suspended during that. So we were able to really take advantage of throughput. And now the big bad companies are coming back and they're doing take back audits for during COVID when they said, no, you can move these patients. So I got about $3 million up in the air in audits, and 1 million is Medicare, who said that patient was in the wrong setting. But it was during COVID, and we had an an 1133 waiver. Now they got amnesia. And I'm going to make one other statement, then defer to Nancy. I feel like the post-acute world has the most regulations of any hospital
Absolutely.
anywhere or non-for-profit. Our Article 28s, our non-Article 28s, our Article 32s, our CON requirements. It just makes more red tape, and it's an inefficient system.
That's the untold story. No one talks about that, about the recoupments. Nancy, do you want to chime in?
Sure. So from the hospital side, and certainly on the post-acute side, it is that prior authorization and that challenge. You know, each insurance company has a different portal and a different set of requirements. And that is a challenge, trying to stay abreast of how we should submit a request, who should be submitting the request. And then when it's done, you know, new documentation is required. So I think, you know, that is the work for us to try and master it, but I feel like it's pretty tough. It's pretty tough. So as Scott LaRue said, you know, when this challenge is resolved, I hope I'm not retired at that time, but I'm looking forward to it as well.
And just for the audience, for you to know, the Medicare Advantage plans are actually supposed to mirror the traditional Medicare plan, but as both the panelists have mentioned, there are some difficulties that the post-acute realm is still experiencing, although they are supposed to follow Medicare rules.
Big selling
Any other?
Wait, the big selling point between Medicare fee-for-service and the Medicare Disadvantage Plan, on the Medicare fee-for-service, Medicare covers 80%. So, old man Edelman, when I turn 65, I have to go buy a gap plan for the 20%. So say AARP, not that I am endorsing them. But the Medicare Disadvantage Plan says, no, don't worry about that. We're going to give you everything Medicare gives you and more. You don't have to pay the 20%. And here's a free tote bag. What they don't tell you is they're going to deny the care you would have received under traditional fee-for-service Medicare.
Anyone else? Scott LaRue, Nancy?
I don't think I have anything positive to add to this discussion. I mean, your best chance with one of the insurance companies is try to get your financial incentives aligned. But their starting line is in such a bad place. It's difficult to create value-based arrangements when the reimbursement they want to give you is already below what your actual costs are to deliver the service. And then as Nancy spoke, then you're fighting to get paid for what they agreed to pay you. You know, this market, if we went back 10 years ago, we were less than 30% managed Medicare in the market. We're about 52% now, and it's having a real impact through the entire continuum. And it definitely contributes to the backing up of patients in the hospital, as Scott talked about, waiting 3 days to get a authorization. That's 3 days they're sitting in the hospital that most likely in some circumstances the same insurance company is paying for, and it's a lower cost of care to move them out into a skilled nursing facility or another setting, or even Calvary Hospital. You know, so it is a very significant challenge that is eventually going to get solved, because in the absence of it, you know, things are going to continue to deteriorate.
I want to add something that both Scott and Scott have referred to, and I'm sure the folks on this call can relate to. This idea of throughput and patient flow. We at a couple of our campuses are bursting at the seams. So we have our EDs are overflowing. We have patients who are admitted who can't get up to a bed because the house is full. And then to Scott's point, it takes 1 to 3 days potentially to be able to transition that patient safely as we're waiting for approval. So it is a real issue. And to the extent that we can shave some of those days, so we can move patients and ensure patient flow. It's critically important. Patients are not benefiting by sitting in an acute care setting, not receiving the next level of care that they need to advance and to get well. And that really isn't a benefit to anybody because the longer they're sitting in an acute care hospital, not receiving what they need, the longer they'll need in another setting to return to their baseline. So, yeah, it challenges us in many ways.
Nancy, and I don't think the insurance company is either smart enough or doesn't care. You're creating a higher percentage of bounce back, right? It's going to be a higher percentage of a post-discharge back to an acute, doubling the cost of care. So that they're happy with $1 today, but it drains the system later, and it's still posting $51 billion of profit.
Before we move on to the next question, should we discuss technology and how we use data for buy-in?
Yep, I'd be happy to start off with that. As I mentioned, we were fortunate enough that we had a large managed care portfolio, and managed care works on data. And it taught us as an organization what data is important and how to use it to best care for the patient and to deliver the best outcomes. And on this post-acute continuum, having access to that with our partners in both directions is an absolute necessity. And I think there's been tremendous progress made in the last really 3 to 5 years to create opportunities to share the clinical information in a timely way. I think we still have a ways to go. We mentioned Epic. Everyone on Epic's got great access with each other. Other partners have some, but less than they would with the Epic system. But there's nothing better than timely data to help you make the right decisions about the care for that patient and having access to it. And there's also a lot of technology coming out now as it relates to managing the patient with less staff in the rooms, whether it's patient monitoring, whether it's AI that's monitoring how a patient moves in their bed and alerting you if their movements are something out of the ordinary, or they might be trying to get out of bed when they're a fall risk, etc. I think that it's wide open in terms of how technology is going to improve our ability to do predictive analytics, improve the care that we provide, and get timely information to our partners along the continuum so that they can make the right decisions as well.
Well said. Nancy, Scott?
Sure, I'll add 2 comments. One around data sharing. In addition to the clinical data, it's those performance metrics that matter. So sharing, understanding what's important to our post-acute care providers, and likewise sharing what's important to us. For example, Scott Edelman mentioned response time, referral response time. So timely responses, it's something that we look at. In addition, in terms of the possibilities with AI and other predictive analytics, using AI to help us identify what is the optimal post-acute care setting for this patient. And having that determined will be enormously helpful. So I think certainly there are people who've been thinking about this, and we'll be hearing more about, the possibilities.
Yeah, and if I could jump in, I think the Epic connection is great. Not every hospital and health system across the country can afford the Rolls Royce of EMRs. My hospital alone, we were on Meditech. probably would have stayed on Meditech when, you know, we joined the health system and it was a priority. Struggles, happy we're on it because it opens up Epic Care Link, Epic everywhere, where MDs can get information. Also was introduced to a new product last week that Epic's going to roll out called Hello World, which you're going to be able to put the post-discharge follow-up right in their My Chart. So that's fantastic. I'm looking forward to seeing what that's like. And AI in healthcare is a long time coming, and we need reliability. We need resilience around it. We need to adapt a change management attitude to get it done. It will not replace people. It will enhance our entire healthcare landscape. You know, if you could take something as a referral coming in and it automatically knows where to populate an Epic, that saves someone 3 or 4 hours of keystroking. And as Nancy said, if there was this box that said, here are all the lab values, here's the diagnosis, press the button, patient belongs in skilled nursing facility, average length of stay, X. You know, that would be great. Still, a clinician will review it, make sure nothing was missed. And one thing I want to add, to enhance relationships, balanced scorecards are key. You know, share back those metrics. Also share news of the organization. You know, if you won an award, if you're on the U.S. News and World Report for back-to-back years and your employees voted you best places to work in Westchester, shout that from the rooftop. If you have more RN candidates than positions, shout that from the rooftop. There was the reason why people want to work for your organization. What are your patient experience scores? That should be shared with referral sources.
Excellent. So let's get to our last question. What are the common challenges in gaining and preserving funding or authorization for post-acute care? I know we started speaking about Medicare, but what else are the other challenges? We'll start with Scott LaRue, and we could discuss staffing as well if you would like.
Yeah, so common challenges in gaining and preserving funding or authorization for post-acute care. That's a really loaded question, Natasha. You know, I touched on it earlier. I think one of the drivers right now of the issues that the hospitals are having is around the funding, especially for Medicaid patients. You could put the managed care conversation aside. You know, we're reimbursed about 65 cents for every dollar of actual cost to care for a Medicaid patient. And if you have facilities that are primarily Medicaid, which are doing more mission-driven work, and they don't have the balance of Medicare or higher commercial payers, there's no way that facility can survive today. So that's creating part of the challenge right now that I think the hospitals are facing. And at the same time, Scott mentioned or touched on this earlier, the regulatory environment is extraordinarily difficult right now. And that regulatory environment is punishing providers who are trying to help their acute care partners who have challenging patients, whether it's behaviors, whether it's substance abuse, whatever it might be. There is no reward in the regulatory environment for taking that patient. In fact, it's just the opposite. It's an unforgiving punishment if something goes awry with a patient that is extraordinarily difficult to manage. And those things are all contributing to this current lack of throughput that Nancy was speaking about and Scott at the start of this presentation. So until those things are resolved, I think it's going to continue being a challenge. The staffing, from my perspective, and you know, congratulations to Scott, because I think he mentioned that he has more applicants than he does open positions. He must be from personal experience. That's a great place to be. Staffing is going to continue to be a challenge for us. It's not a limiting factor at this point. I think we're in a much better place in the market. It's loosened up a little bit. There's more availability, and there's a lot of effort going into creating opportunities for people, to become CNA to LPN to RN, or to go to school and get your education and widen the pool of applicants. So if I was to list the top two challenges, I'd put the reimbursement and the regulatory environment as the two that we're facing.
And I'll jump in, Scott, on your regulatory statement. Whenever you're doing anything with the state or the feds, you have to submit a perfect paper. It's like being back in school and trying to maintain, I've got 100 on each of the spelling quizzes. And they will still find a way to say no. Okay, you took this patient, it was 1 hour before you could have taken the patient. Or they don't extend a continuation of stay because the person lost their insurance during their stay in your hospital. Okay, and what we're trying to do is take care of patients. That's what we do. We are mission driven. Yes, we want to make a profit so we can invest back into the organization, but we're handcuffed every day. 65 cents on a dollar with a high Medicaid is rising. Medicaid is rising. When we don't cherry pick and say, oh, I think I'll take 20 Blue Cross today. That's not what we do. And staffing's still an issue. Don't know what gift we would just give in with all these applicants. I'll attribute it to culture and doing a really good job with recruiting. I need 50 therapists with a very ambitious expansion of outpatient program. And I would also say the biggest risk right now is regulatory risk. And with new government coming in on the Fed side, we don't know what Social Security will look like, what Medicare looks like. Will the Fed still let the states run Medicaid? Will it get worse? Will it get better? We don't know.
Nancy?
Sure. I think what I'll add simply is that the challenges that they face back up into the hospital. So if they're unable to take some of our patients for all the reasons that they've described, it creates that logjam and it becomes very challenging. And we end up investing a lot of resources in trying to find a pathway out of the hospital for those patients who don't belong in the hospital. So you can see, back to strengthening the continuum, we're really, really connected. And the post-acute care success is the hospital success. And I don't know how to think about it any other way than that.
Well stated. Should we go into the Q&A from the audience? I know there's a couple of questions coming in. So the first question, what is the role of technology? What is the role of technology in helping monitor, assisting on the care of the patient, seeing as how staffing is a problem for everyone?
Natasha, can you repeat the question, please?
Sure. What is the role of technology in helping monitor, assisting on the care of the patient, seeing as staffing is a problem for everyone? So how is technology able to assist with staffing?
Well, I guess
go ahead.
You go ahead. I defer.
Yeah, I was gonna say there's a few things that are happening that I mentioned that I think are helpful in pointing things in the right direction. So, of course, you have beds now that take weights on patients, take vital signs on patients. The information can be automatically transferred into the electronic medical record. You certainly got portable vital sign equipment that, although, not on the bed, but the nurse can take those things and they get uploaded. You've got, your automated pharmacy. You've got
It's frozen?
Yeah.
Yes.
Might have
I'll pick,
froze.
I'll pick
Okay.
up from
Time.
until he comes back.
Oh, he's
Are you
here
back?
he is.
You've got technology, as I mentioned, that's starting to be developed that I think can be very useful in trying to prevent falls. I mean, those bed alarms, to me, they're nothing but an annoyance. They're not doing anything but alerting you after somebody fell. It's a rarity that, someone hears that alarm and they could get in the room to
Right.
prevent it. And then, all of those things can help reduce the burden at the bedside, to the caregiver. So I think we're at the front end of this, Natasha, and I can't wait to see what some creative and innovative people come up
Right.
with. I know one of the barriers here is security, and the lack of security that some of these companies have with their new technology.
Right.
And that in itself has been a bit of a barrier to meet the requirements. So I'm excited about what's coming, and I do think there'll be real opportunities to help reduce the burden at the bedside.
Yeah, and if
Agreed.
I could jump in. We all have our phones very handy. We live with our phones now. 10, 20 years ago, it wasn't that. Even before that, I'll date myself. There were pages and beepers. Integration of an online scheduling system for clinicians is fantastic. Shoots out a text when it's an open shift, someone grabs it. We didn't have that before, so that really cuts down on somebody dialing, hey, Jill, can you work? Hey, John, and going back to what you said about beds, we just invested and we're doing them unit by unit. They're very costly in new Hillrom beds, and they're about $10,000 each. And there's 3 lights on the floor, and it tells you bed alarm, seatbelt, positioning, which helps prevent bed sores. And it's all integrated into Epic, and you can see it on the dashboard at the nursing unit. Taking advantage of economies of scale. If there's something the health system has and it's working, how do we get a site license for it? We don't want to go out there and try to recreate the wheel if someone's already doing it great. And there also needs to be synergies in all of our health systems. And I know we call each other and we say, oh, are you aware of this? Does it work in your organization? How do you use it? And I think that's important. And we've only scratched the surface on technology. And we all have these great IT departments that are looking at AI and how does it work with all of our types of organizations.
Next question is, are the FQHC, the local health departments, and the provider offices included in the post-acute partnership? And how do they play a part?
Well, I'd be happy to take first shot at that question. The first 1115 waiver, which was focused, called DISRIP. A lot of people debate the value of what came out of that, but there clearly was a better sense of coordination, collaboration at the end of that effort, which has not gone away. I think it was embedded in what we do. The second 1115 waiver is really focused on pulling these community-based organizations into the support that the patients need when they're discharged from an institution and to make them successful in their community. So they have a very valuable role. And as they move down the, the continuum ladder from acute to subacute to CHA to assisted living, whatever might be next, it's those organizations that are going to be the key to keeping them healthy and out of institutions. So they have a very critical role.
Scott?
I defer to Scott. He sounds more subject matter expert than me. That's a little bit of the deep end. New York State needs to come up with better plans. As they did change DSRIP. They need to allocate the resources to the right area. And we can't forget we have a very large aging population, and they're the forgotten population.
Nancy?
I'm deferring to Scott LaRue too.
Okay. And just to add in, the local health departments do have programs like the nursing home waiver program, as well as the TBI programs. But just like us, we are continuously working, and it's just, I believe Scott Elman said the population is growing, and there are also backlogs in those circumstances. Next question. As we move forward in the acute to post-acute world, are there any opportunities to use AI to assist with throughput?
Yeah, and I think we kind of said it. If AI can help us determine the best setting, like 1-800 post-acute, where should this patient be, right? Based on all these variables. And also AI to either dictate or populate screens and let a clinician do their work, which is analyze, can this patient do 3 hours of therapy? Can this patient tolerate 1 hour of therapy? Where should the next step be? And that's where AI can help us. It's going to have to show consistent concurrence with the clinician, because no one that I know would rely on a decision of a computer unless we can concur and have good reliance on it.
We're just beginning to do this, Natasha, and I don't know whether you want to call it AI or a bot, but a good example would be in our home care agency, where individuals used to be constantly checking Medicare and insurance eligibility, because it can change, as Scott mentioned, from the point of admission prior to discharge. And that's all done automatic now without a human being intervening. It just automatically goes out and checks the eligibility, and we get a exception report. Instead of being 1,000 people, might be 30 people that have to be looked into and reviewed. So any function that is easily repeatable and pretty consistent, I think there's going to be an opportunity, an opportunity there. But you take the AI, I think it's an interesting use. As we were talking about hospice, and we're talking about referrals to the hospice program out of the nursing homes, and the first thing, well, I don't have any. And I'm like, well, so you're telling me in the next 6 months, not a single person in the nursing home is going to die? I said, that you guys are miracle workers. There are people in that nursing home that are going to die in the next 6 months. And I think that that's an example of how artificial intelligence can identify and help predict those kind of things. And it gets more timely care to the patient, and helps point people in the right direction, maybe sooner than they would have otherwise noticed. So again, I think another exciting area to see what comes out of this.
Yeah, and one other area AI can help, I'm leery about it, is going through 50 or 60 applicants and determine who's the right person that fits the job you're recruiting for. And I still am a believer in face-to-face means more than what's on a piece of paper.
Nancy, you want to jump in?
Yeah, I think I would just add that the opportunities and possibilities are endless here. And I think there is a lot of really positive ways to use AI in this arena. So I think we'll see it grow probably exponentially over the next couple of years. So also very excited to see the possibilities.
Same here. To Scott's point, one of the things that we need to, and we didn't speak too much about hospice, but one of the things that we do realize throughout the country is that not enough referrals are being made to hospice timely. So I think AI will play a great benefit to actually identify when a patient is at the end of life and really starting to have that conversation early on.
Yeah, I might add that. I know Scott was referring to patients in the skilled nursing facilities, but also in the hospitals, right? I think it could be very valuable, especially at that point when in some cases it's potential transition to GIP hospice, inpatient hospice, and can we quickly identify the right candidates? Because sometimes that's a back and forth, and I know the regulations are so strenuous about who in fact can qualify for GIP hospice. So that's probably a good place for it as well.
I think we're up. Do we have a few more minutes? Okay, I'm getting the cue. It was
We're
a
at
great
time.
discussion, but I'm going to turn over to Darren. Darren?
Well, good evening, everyone. My name is Darren Daraj, and I am your 2024 Healthcare Leaders of New York President-elect. I just want to say what an incredible evening, great conversation, great discussion. Thank you so much to Natasha, Nancy, Scott, and Scott. For the rest of our members, those on this Zoom and abroad, please join us at our upcoming events, our Frank Camerano Memorial Dinner and Lecture at St. John's University, November 19th, and join us at our holiday party inducting our new 2025 board at Terrace on the Park, December 3rd, and closing out the year, another in-person event at Westchester Medical Center, Developing High Performing Teams on December 5th. Thank you all. Next slide. We truly hope to see everyone at those upcoming events. And once again, we can't do what we do, offer the value to our members and abroad without the dedication and sponsorship and support of our sponsors. Thank you to our sponsors. Thank you to our panelists, moderators. Thank you to ACHE. And I will give the mic off to Nan from ACHE to close us out. Nan?
Great. Thanks, Darren. All right, everybody. Thank you for your participation tonight. On behalf of ACHE, I too want to thank our chapter leaders, moderator, panelists, and everyone for their participation. I have put the evaluation link in the chat a few times. Hopefully you were able to grab it. Please feel free to grab it from the learning management system as well, where your course is located. That does conclude our session for this evening. Last thing I need to say, it's copyrighted in 2024 by the American College of Healthcare Executives. All rights are reserved. Thank you, everyone. Enjoy the rest of your evening, and hope to see you back again sometime soon.
Thank you.
Thank you.